Hello and welcome. Thanks for tuning in to today's episode. This is ASAM Practice Pearls, a podcast series from the American Society of Addiction Medicine. I'm your host for today's episode, Dr. Stephen Holt, and I'm thrilled to be joined by two distinguished experts and friends, Doctors Carolyn Chan and Shawn Cohen.
Hey, everybody. I'm Dr. Carolyn Chan. I'm an internist and an addiction medicine specialist.
And hey there, I'm Shawn Cohen. This is officially the first time I've ever been called distinguished, but I'm also an addiction medicine doctor over at Yale and a general medicine doc.
Today's episode is part of our Advanced Buprenorphine Education series, where we discuss common buprenorphine implementation challenges in both hospital and clinic settings. We're diving into a topic that's critical for improving patient care, and that is overcoming barriers to MOUD at the time of discharge and ensuring patients have a smooth transition to and from skilled nursing facilities. Transitions like these, as we all know, can be incredibly challenging, and it's really a vulnerable time for patients. But it also gives providers an opportunity to make a significant difference. So let's kick things off with a case example to frame our conversation. Today, we are considering a 64-year-old man with a history of newly diagnosed opioid use disorder and chronic pain who is recovering from a hip fracture he sustained when he stumbled going up the stairs to his apartment. After nearly a week on the orthopedic service, he is successfully initiated on buprenorphine, and he's slated to go to short-term rehab in a day or two. However, discharge planning hits a major roadblock. The short-term rehab doesn't actually carry buprenorphine, and they require that an outside prescriber continue this medication. His outpatient provider, who had been prescribing nearly 180 milligrams of oxycodone to our patient daily, is unwilling to take on the buprenorphine prescription. And even more, the preferred pharmacies that we would use don't even stock buprenorphine. His family is growing frustrated, and without a clear plan in place, the patient is at risk of being discharged without access to this essential medication. So, in this situation, what could be done differently to ensure patients like him have uninterrupted access to medication for opioid use disorder? And that is exactly what we, with my colleagues, will be unpacking today. So, first off, Dr. Chan, Dr. Cohen, thinking about the big picture here, stepping outside of this particular case, you guys do a lot more inpatient medicine than I do. What are, in your minds, the most common barriers to ensuring continuity of care for our MOUD patients at the time of discharge when they're going to skilled nursing facilities or things of that nature?
Yeah, I mean, I always think about it's worth taking a step back at the bigger picture. I think that a lot of the issues that this patient was having, and particularly probably with the skilled nursing facility as well, come back to this stigma that we see, one, in society, but I think too often in healthcare settings around substance use disorders and around treatment of substance use disorders. And I think that a lot of it, comes back to the stigma, and the medications become this easy marker to be able to identify people with substance use disorders for people to be able to decline care, not want to take care of. I think there are, truthfully, for nursing facilities, there are other logistical issues that I think are more relevant, honestly, to methadone often than to buprenorphine, of like, how do you coordinate with an OTP? How do you ensure things like chain of custody, where the methadone can get from the OTP to the nursing facility and things like that just don't exist with buprenorphine. I think a lot of it is lack of education and stigma that comes down to it. It's always worth taking a step back and saying, like, declining someone care at any type of medical facility, including a nursing facility, because they have a substance use disorder or because they're on treatment for substance use disorder is illegal under the Americans with Disabilities Act. And so there's lots of avenues to try to address this, from the legal aspect of getting lawyers involved, talking with your local attorneys. But I think from the partnership building aspect, I think a lot of the reasons nursing facilities often decline these patients is because they have this idea that they're going to be quote unquote difficult, that's based on these often, I think, stigmatizing ideas that they have in their head about substance use disorders. And so starting to talk to local nursing facilities, building relationships with them, making sure whether you're the outpatient or the inpatient doc that's helping out with the addiction thing, they know that you're a resource to them that can talk through the buprenorphine, that's willing to prescribe the buprenorphine and other meds while they're in the nursing facility and kind of troubleshoot whatever the things are, is a step. But I think often to address this requires multiple steps from multiple different avenues too.
Along that line, same thing. building that relationship with the intake coordinator, I feel like is often one of the key things. I have a number of nursing homes that I know will often accept my patients, and those intake coordinators, I have their phone numbers, they have my number. I make it really as easy as possible to let them know that they can call me if there's any issues. They don't have to page me. They have my personal number. And I think that goes a long way. As a physician who gives out their number at these scenarios, it's not like I get flooded with phone calls. It's just like a really nice way to sort of ensure, number one, continuity of care for patients to make sure that they're getting evidence-based care. And two, like, hey, I wasn't trained well in addiction medicine. I felt like I received a lot of my knowledge during fellowship. So being sort of like thoughtful that like, hey, sometimes people just feel like they need that extra support. Oftentimes the nursing home physician will take it over. And in my experience, if they know who they can reach out to if something happens, and it's challenging, right? Because the systemic and structural issues, Shawn, that you're describing, it takes a long time to do those things. So it's like, what am I going to do right here and right now for that patient? I've noticed as well that sometimes depending who you talk to on the day of who's doing the intake, somebody will say no when you're like, I know that facility will take my patients. So again, just like knowing the local facilities well and how to sort of like advocate and making sure that policies that the nursing home have are implemented in an equitable manner is important.
It's interesting to me. I hear some of the things you're saying and they sound like advocacy, right? A lot of times we think of advocacy as like going to Washington, D.C., or it's writing op-eds, or, it's doing those kinds of big picture things. But advocacy is just knowing the names and the contact information of someone who works at a short-term rehab or nursing home who you're advocating for this patient for. You're calling and you're saying, hey, look, you know me, my friend is your friend. And, this is a patient who really needs this medication, needs to be placed at the center. And it's that extra work against those phone calls that I think can really transform things for our patients.
Speaking to what Carolyn said too, of like there's this huge gap in education around effective addiction treatments and buprenorphine and methadone. And so I do think there's this huge education barrier where like I've definitely spoken with people at nursing facilities that say, oh, we don't have a physician or a clinician like an APP that can prescribe buprenorphine, and having to do that education of there's no such thing as an X waiver anymore. If you have a DEA, which you definitely have a DEA, if you're working probably at a nursing facility, you can prescribe this. And even if they're still not comfortable saying like, I'll send a 30-day script, you can call me in a month, just taking away whatever barriers pop up too.
That dovetails nicely with my next question, which is we were just focusing on getting to a place and figuring out what the stigma and other barriers are to getting a patient from the time of discharge to an STR or what have you. I do a little bit of time on the inpatient side for this. And one of the things that comes up is you write a prescription for maybe it's XR Bup, maybe it's Suboxone films or tablets. And the patient's now left the hospital and some prior authorization issue comes up. It's kind of hard to anticipate even those things. How do you guys deal with that? Can you deal with it? Is it sort of up to the outpatient provider? Like, how do you handle issues with prior authorizations when they arise in those situations?
Yeah, especially with things around methadone and bup, I tend to double check things. I mean, this is true for going to a nursing facility, but also often if I'm sending bup to a pharmacy, I've never sent it before. I call the pharmacy and I'm like, did you get this prescription? Are you able to fill it? Do you have enough for the month? Because I've had it where people show up to a pharmacy and either one, they don't stock it, or two, they're like, well, we have 3 days, we can fill that. And then the patient has no way to contact too. And so I am very much in the mode of, I think transitions of care are the places where people get lost or things happen in a bad way the most. And so those are the times where I really try to double check things.
When possible, I like to send the prescription to the hospital discharge pharmacy just because I know if there is an issue, I'm going to get contacted. I do have a sense of common challenges that happen for patients who are on Medicaid, or I provide care in a city that borders on 3 states that have different rules. So over time, I do think we learn some of these. And, if you're supervising learners, you really should be thoughtful and sort of coach them through some of these things. 'Cause I do think after a while, we're like, hey, we know that we're going to have X problem with combination product or mono product with this insurance. So sort of trying to keep track of that and confirming again that things go through when possible is key. And also, even when we're thinking about discharges to nursing homes, there can be some details that are really important, right? Like, hey, if it's the nursing home doctor is going to take it over, but they only come in on Wednesdays, how long should I send the prescription for before that doctor comes in? Some facilities say, hey, no, we always just use X pharmacy for everything. We don't want any bridge scripts. it's going to be sent, here, and this is how we do it because this is how we deliver it, etc. So I think really working closely with the case manager to clarify the details of prescription delivery to the nursing homes and how that process works is important.
And how does that change when you're talking about methadone and trying to continue that and you're discharging a patient on a Friday to an STR? Like, how do you guys get around those particular challenges?
Methadone comes with its own bag of regulations that do make it harder, definitely for nursing facilities to take people with methadone. But I think some of that is they make it easier for them to say we can't provide methadone because there's too many barriers to it. And so there's lots of steps, I think, that nursing and relationships like nursing facilities need to know the OTP, be able to get methadone delivered, or there are situations where nursing facilities can open up a satellite OTP location within the nursing facility and just provide methadone that way. So there are ways to do it, but I think it relies on not only building relationships, but a lot of coordination between the nursing facility and an OTP eventually. But for the specific on the Friday discharge, I think there was a period of time where we would just wait till Monday because we just didn't have an avenue. But there is now the 72-hour rule, which is a way that hospitals and in some cases, outpatient clinics can dispense but not prescribe. And so that's like fill methadone for up to 3 days from like an inpatient pharmacy through the Pyxis or through the inpatient pharmacy that you can then hand to a patient to leave with, whether it's to a nursing facility or to the community. There's a couple of good papers that we can maybe link in show notes and stuff like that. That's talk through how to actually implement that in your care setting too.
And I want to pause and actually just do a high level overview in case some folks may be working in places that have really low level access to methadone. So just to sort of remind everybody that methadone for opioid use disorder cannot be prescribed via a prescription. You can prescribe methadone for pain, but not for opioid use disorder. So methadone for OUD has to come from an OTP, which stands for an opioid treatment program. So what this means is if a patient is going to be discharged, they have to essentially be able to start methadone at an OTP the next day of discharge and to get it off and delivered to their nursing home. So often what this means if it's a patient who has newly started methadone, so I think it can vary a little bit if somebody's already been established at a methadone clinic and it's more continuation of care. But if it's a brand new start, they have to be discharged on a day in which the methadone clinic can do their intake often. Not always, but like the next day. Different methadone clinics have different hours for intakes, just in the same way that different clinics have different hours for which they can see patients. So you often have to coordinate with the clinic to say, hey, when can this person come and do their assessment and their physical exam and start the methadone? And then the second piece is nursing homes very rarely, actually, I don't know of any in my area, they don't actually bring the patient every day to get dosed for methadone. What they do is something called chain of custody, which is what you referenced, Shawn. So essentially, either the nursing home on the first day will send somebody with the patient and they'll sign forms, and then 7 days of methadone is often handed to the healthcare facility worker, and then they dispense it at the methadone clinic rather than having them come dose every day. And I think that methadone clinics, you said, Shawn, too, in your area, they'll deliver it to nursing homes.
Some of them, yeah. There's a couple of different ways to do this. And then, so I think some deliver it, some the patient has to go. There's one methadone clinic that basically has an office in one of the nursing facilities. And so they can actually see patients there and dispense the methadone there. So there's different avenues that have different amounts of barriers too. But there is more leeway in the newer updates to the methadone regulations in terms of clinics being able to, if you have a relationship with a clinic, them being able to like use your physical exam and some of your information to be able to like dose someone for a couple of weeks before they do a full formal intake at the OTP. But like everything in addiction med, because the process is a little complicated and there are so many barriers often. So much of this is knowing your resources, having relationships with your OTPs, with your nursing facility administrators, with your intake people, so that you can help kind of connect people together and figure out a plan to try to help the person in front of you.
Thanks for that. Let's talk about, there's an increasing prevalence or increasing access to extended release buprenorphine options at the time of discharge. So for you guys, when you decide that, getting a person on XR Bup on the day of discharge is something you want to do, it's good for the patient, it's going to keep them safe for whatever stretch of time, do you always make sure that you have a follow-up plan, that you have somebody 30 days from now who's going to take over? And how do you guys manage that? What's sort of your approach to XR Bup on the day of discharge?
Yeah, I mean, I feel plus and minus about this because it's much easier, I think, for a nursing facility to be able to continue a med they can prescribe. But I think like if XR bupa is what this patient wants and what they feel like is best for them and we feel like it's best for them, I think they should get it before discharge. But I think a lot of it is knowing your community, the clinic that they're going to follow up in. And I think we often like turf a lot of follow-up care when someone's at a sniff to figure out after the fact. But I think this is one of those times where you're like, you have to be proactive and either make sure they already have a follow-up appointment that the nursing facility is aware of, that is considered like a specialty appointment with an addiction provider. So it's not primary care that the nursing facility covers, and that clinic is willing to either get an appointment a couple weeks before so they can order the next bup shot, or they're willing to pre-order it on essentially your word that this patient's going to show up. And then again, like, as you can tell, I'm probably a little neurotic, but in these cases where I'm worried about transitions, I would send myself an epic message like 4 weeks from now to remind myself that this is going to fall through the cracks. And so please double check that it didn't fall through the cracks.
Similar, I will offer to pre-order it, especially if the patient's going to come to a clinic in our system, just because I know that it often has to go to a specialty pharmacy. So it's not quite like sublingual bup where the expectation is many pharmacies have it. And if one doesn't, you can usually find another one pretty quickly to get it same day, but it will often take like 1 to 3 days to get shipped, assuming that there's no holiday and, nothing crazy going on. So I really think about that. I really agree that I try and schedule them ahead of time and let the nursing home know what the appointment is for. So they don't think that it's like, oh, this is like a random primary care appointment that I can just cancel, because we already have somebody managing that, being very clear on what the purpose is, because sometimes stuff happens, right? And people, for whatever reason, aren't able to get to their appointments when they go to a nursing home. I also think that if I'm starting it on discharge for the first time, it's pretty common for people to need additional sublingual buprenorphine during that first month. So in my practice, I definitely counsel patients on that expectation, will encourage and actually usually prescribe like 8 milligrams as needed PRN daily for patients on top, just to sort of help manage any cravings that may happen until that medication gets to steady state, which can also be confusing to the nursing facility, right?
Yeah, I was just thinking that. I mean, it's tricky enough sometimes for us to give that out, even though I think we're more and more often doing that. But I could just imagine, like, so here's a PRN medication that maybe they won't need for about 2 weeks, and then all of a sudden they'll want to use it on a daily basis, and by the 4th week they might ask for it twice a day, and that is tricky, especially if you don't even know how long they'll stay, how long they'll be at STR. Yeah. Well, I wanted to pivot a little bit to change gears and talk about, to what extent do you see providers engaging with family members or caregivers or other people in this patient support system as important to ensuring a good transition of care? Like, do you ever touch base with, obviously in a HIPAA appropriate way, with your patients, significant others, or family members, support systems, et cetera, to help this?
I mean, I leave it up to the patient always. One, I think we have to based on 42 CFR and all that stuff. But 2 is I'm never going to try to engage a family member, caregiver, whoever, someone important to this patient behind their back to try to push something that I want or the family member wants. And so I would say if the patient feels like for us to build a plan that works for them, whether that's at the nursing facility or just an outpatient plan where we're trying to help with a transition of care, and they know that like I'm going to be around this person a lot and they can kind of help ensure that I remember my follow-up appointments and that kind of thing, then yeah, I'm definitely going to call that person or have them come into the hospital and sit down and kind of talk through things and write things out for them too. I think we underestimate how confusing hospitalization and transitions of care when they're here for cellulitis and they also have a new diagnosis of diabetes and they just got started on bup and there's 15 different new medications that are at 3 different pharmacies and clinics at 3 different sites, and how are they going to remember which clinic is the buprenorphine clinic, right? And so I think as much as they're interested in engaging people to help make sure the plan works out, I think is important.
Yeah, that makes a lot of sense. Especially, like you said, those patients who have to see a cardiologist, an infectious disease doctor, a cardiothoracic surgeon, and God forbid, the addiction medicine provider at the end. So having another party helping with that, with the patient's consent, makes a lot of sense. Returning back to your comments earlier about stigma and nursing homes or short-term rehab places being somewhat resistant to accept our patients with substance use disorders, do you see a role at all for staff education at nursing facilities And to what extent can educating other providers, be they nurses or other staff at nursing facilities, can that help to grease the wheels, so to speak, so that they're a little bit more willing to accept patients with substance use disorders? Any thoughts on that or an experience in that space?
I have been like a very small part in a bigger movement towards getting some nursing facilities in the area I work to start accepting people. But I think the bigger reason that things changed was because there was a person within a nursing facility that became a champion for this type of thing. And part of their being a champion was making all the relationships with one, consult services, but two, OTPs, people in the nursing facilities, and them internally, I think, doing education, starting to take these patients and showing that the world isn't going to end. These are just normal human beings that need help. And so I do think someone within the system to change it goes a lot more than the external someone wagging their finger. But that being said, I think that pressure to change things, and I don't want to paint all nursing facilities as these terrible stigmatizing places. I think it's more of a societal thing that we often stigmatize substance use disorders, and that pervades all these institutions we work at. But I do think that to really change things, you often have to go from multiple avenues. And so that's internal change agents, pressure from regulatory authorities that this is clear discrimination. If it's needed, like pressure from the legal aspect to say like, this is illegal that you're doing. And I think in Massachusetts, there have been a ton of settlements with nursing facilities that were declining people on MOUD because of that. And I think all those things, I think together eventually change the system.
And for people who are trying to do that locally, be patient. Don't be frustrated. It takes time. Similar to harm reduction, right? We talk about any positive change, and acknowledging that like sometimes things get better at like smaller incremental ways. And that is still really valuable. And those efforts are worthwhile. So it can be really frustrating to work in this space and to be an advocate in this space. I think many of us here have experienced that, right? But keep at it, be flexible, build relationships, and just be persistent, and work with people. And if they're going to give you a movement on something small, take it and just start there and just kind of try and keep moving forward a step at a time.
So can you think of a success story, for like a challenging situation, much like the one that I outlined at the beginning of this episode, an example of effective MOUD discharge planning despite all odds that could potentially inspire some of our listeners?
Fortunately, I will say, I think some of the MOUD discharge planning that goes well as a inpatient doc, like the ones that go well, I never hear about, which is probably good because I don't see them again, right?
That's true. Yeah.
The ones that I like that always come back to me are the ones where like all those layers of Swiss cheese, like one of the layers caught somebody. And so it winds up working out of like patient who went to a nursing facility, leaves a nursing facility, but wound up having the consult service phone number. And so calls the consult, because we have like a landline. I know, very weird, but we have a landline in our office, and calls the consult service phone number. We give them a bridge clip. I message Steve, he gets them in 2 weeks, and then like, happy story. Those are the stories that stick with me, of like the patient trusted us, found a way to, with all the kind of extra layers we tried to add, found a way to make it work.
I love that. Like somehow at least the patient held on to that little business card with y'all's number on it. And that was a sufficient little bit of safety net. Carolyn, I don't know if you had a similar type situation you wanted to describe.
I want to describe a scenario just to remind people that there are places that have methadone clinics associated with their healthcare system. So we had just a challenging scenario where a patient, just due to medical conditions, was just like unable due to acute medical process to actually like get even in a wheelchair into the OTP. So they're essentially bedbound again due to just ongoing medical issues. So we just did the intake in the hospital. I'm lucky that we have a healthcare system that has a methadone clinic. So we actually developed a process where we just did everything in the hospital for them as a new patient, which is very unusual. Though, again, looking at ways to be creative, that was kind of cool. And again, to sort of align what Shawn says, like this idea, the biggest gap I see is what happens after the nursing home. There's just so much that has gone on for that patient. So much time has passed. Like really anytime a patient shows up after a nursing home to my clinic, I'm like ecstatic. I'm like, yes, you made it here. Like they're all successes, but like sometimes what I'll do is like our office also has cards, like we'll encourage people to take a photo of it on their phone. And if they lose all their paperwork, hopefully they can like pull up the number in their phone, really to care or re-strategize. So sometimes again, we'll get calls as well and can help a patient be like, where was I supposed to go again? Like, by the way, now I'm like 2 hours from where I thought I was going to be. What do I do? Like, where are you staying, sir? Like, that is very different than the last plan.
Nice. So let's start to close out here and we'll get some key takeaways. Let's first revisit our case that we started with. So again, we had a 64-year-old gentleman, newly diagnosed OUD with chronic pain. He had fallen down the stairs and sustained a hip fracture. And now, after having had his ORIF of his hip, he is getting ready to go to short-term rehab and is experiencing some barriers vis-a-vis some limitations on buprenorphine access at the facility that he was going to and outpatient prescribers who aren't game with prescribing it. So take-home points here, just to summarize on things that we have gone over during our talk today. Shawn, can you give me sort of your first key point on what we've talked about and how it applies to the patient that we've introduced?
Yeah, I mean, I think about one, and I think you brought this up, Steve, is like embrace your role as not a big time advocate and going to Washington, D.C., but as this like local advocate that can build relationships, get to know your local nursing facility administrators, intake people, buprenorphine clinics, so that you're able to be that person that can talk to everybody and kind of help smooth the road for this patient and plug the holes where they wind up coming or provide the prescriptions where they're needed.
I feel like that summarizes it so well. Also, be familiar with the details of your health system and plan, right? Think about the specifics of the buprenorphine. Where is it going to go? Is it going to need a prior auth? Is there a way I can call and confirm if there's any uncertainty in terms of whether a patient is actually going to be able to fill it when they show up?
Awesome. All right. Well, thank you all for tuning in to ASAM Practice Pearls. I again want to thank our distinguished experts, Dr. Carolyn Chan and Dr. Shawn Cohen, for sharing their invaluable insights on overcoming these common barriers that we see with our patients with MOUD at the time of discharge. For more information on buprenorphine implementation, check out ASAM's new Advanced Buprenorphine Education series, which focuses on addressing common challenges in hospital and clinic settings. Remember to subscribe and share this episode with colleagues who may find this information helpful. We'd also love to hear your thoughts. What challenges have you faced in ensuring continuity of care during patient transitions, and what solutions have worked for you? Be sure to comment and join the conversation. Otherwise, thanks for listening, and we will see you next time on ASAM Practice Pearls.